And then let me share the screen. So SLP215 are swallowing disorders. Now, before we go any further, two things. So as SLPAs, you won't be treating feeding disorders with regards to swallowing. So typically, as of right now, I do anticipate maybe some changes with regards to this. I do see where that could change in the near future, especially now with some of our ASHA certs that is going on and this whole new ASHA SLPA certification. I do anticipate this. Now, the whole reason why we do spend a whole module on it is for one very important reason: to understand what you're licensed to do now, and understanding when you need to have your supervisor's input. So for two things is you need to know what it is and why you don't do that, and when you need to alert your supervisor. So you're clear on boundaries, because we'll talk about some situations where this can come up. So swallowing disorders. So typically speaking, SLPs, speech therapists in general, when we do feeding, because it comes up a lot, especially in Arizona, with regards to feeding therapy. So typically, and I say typically, I'm not saying all of us, but in the general scheme of our profession, so we're really trained on swallowing. Can someone safely swallow? Can they get the liquid? Can they get the food, safely into their stomach and not into their lungs? And so let's look at some, and dysphagia, although I feel like I say it different because I was trained in the Midwest. So I think it's dysphagia. It's more of like a j, and I say dysphagia. I don't know. I don't think even ASHA has a consensus on how to say that word. Whoops, wait. 1 second. I don't want to go to food sensitivities yet. Sorry, I always do this. I hit the wrong next button. Okay. So it's a term that we use to describe a disorder of swallowing. Oftentimes that'll be on somebody's discharge papers. It's a medical term. And then what are the consequences of dysphagia? Obviously, choking is one of them. And aspiration is really kind of our true concern, because aspiration itself is the inhalation of a foreign object, including food and liquid, into the lungs. So you can aspirate other things, but food or liquid into the lungs. Okay, and then why is that bad for our health? Oh, sorry. Let me just, typically speaking, when we aspirate and things go into our lungs, we become more at risk and high risk for aspiration pneumonia. So pneumonia definitely is something that happens if somebody's aspirating food and liquid on a regular basis. And that can be, obviously, make somebody very ill and sick, and people do die from this. So, or can, I should say. So we definitely want to make sure people are safely eating. So some causes of dysphagia. So there's acquired or traumatic brain injury, which we'll talk more about later on in this class. Other neurological deficits, cancer, MS, so multiple sclerosis, ALS, and Parkinson's disease. So all of these things that we might see in the realm of speech can cause dysphagia. And then we have other complications. So anoxia, so they can be loss of air, pneumonia, other seizures, lesions from intubation, all might contribute to dysphagia. So seizures, how that contributes is it might do brain damage, or when I say brain damage to a nerve that helps control swallowing, or the muscles that control swallowing, and then intracranial pressure. So that can be things like not just hydrocephalus, but other things related where it's causing fluid on the brain. and it's definitely impacting nerves. So if nerves are impacted, that can definitely affect how we swallow and how our whole system operates. So 4 stages of swallowing. So be familiar with these. These will come up. Oral prep, oral, pharyngeal, esophageal. So swallowing technically takes from, start to finish 8 to 10 seconds. I don't know. Sometimes I think I inhale my food, so I need to slow it down. Definitely sometimes not taking my time to sit and chew and, relax when I eat. Never good. Don't eat in haste. Never safe. So here's some views of some normal swallows. So kind of, here's the food moving, the pharyngeal constrictor pushes it down, it goes down. So what are symptoms of dysphagia? So here are all the things. So this is what, when looking at this, here's what I want to say. Oftentimes we'll be working with a client, because what we also see is some of the disorders we work with who will also have speech and language deficits oftentimes also have dysphagia. So really being aware of what does that look like. And these are things you guys need to be aware of, because these are things you might need to be alerting your supervisor to. So oftentimes, if you see someone eating or even our own loved ones, these are just good things to know. So reddening of the face, they're constantly getting red when they eat, choking while eating consistently a lot, having what I call that wet vocal quality. So if you ever drink something and you feel like it's kind of like, makes that gurgly or that wet, what we call wet vocal quality, pocketing of food, labored or effortful swallow, complaints of food sticking to the throat, or facial grimacing when they eat. So these are all things that might occur. You might notice in working with a client on other things. So oftentimes, especially in a rehab, so when we're looking at you're doing stuff in outpatient or inpatient and food's involved, you might be doing some daily living things with somebody in therapy that, food's involved. You might notice some of these things. So definitely it comes up more often than not with regards to therapy, because oftentimes we are treating them for other things, not necessarily always dysphagia to start with. So here's some of the assessment. Oftentimes we're doing this in inpatient. We're also doing this with babies. We're doing this with anybody that we have concerns about eating, swallowing, getting their nutrition. So for instance, my sister-in-law, she's an SLP. She was at Cincinnati Children's Hospital, and she did a lot with cancer and cardiac patients who were there. And oftentimes they had a lot of swallowing and feeding issues for various reasons. And so these were just all things that they had to be on alert. And oftentimes even someone who's just inpatient and we're checking on them or making sure that things are quote unquote status quo. So definitely we review these things. These are things you might need to alert somebody to depending on your setting and your supervisor for sure. So special diets, we'll talk about in just a second. So an SLP typically assesses this by giving a modified barium swallow study. We do bedside swallow studies. And there's some other instrumentation and honestly, what's nice about technology is improving, getting faster, more readily accessible. So what's nice is that I think this is just going to continue to be quick and improved and with less exposure to other things. I think we'll see some more different types of swallow studies than just modified barium swallow studies. So they're not necessarily swallowing the barium, getting exposed to, radiology. And typically your supervisor will do a modified barium swallow study with the radiologist. So So radiologist, radiology technician, and the SLP are all doing this test together. If anybody's seen one or have had to do one, I'm sorry. But definitely they're helpful and it gives us good information. And that's really to us the gold standard on what would the patient need. And usually what we know by the time we're done, what's the safest and least restrictive diet and what compensatory strategies should be helpful for that client. So here's the dietary levels. Please be familiar with them, especially if you work in a skilled nursing facility, any type of hospital setting, or like outpatient. Be aware of the levels and what that means. And if you're not sure, please, ask somebody. So liquid recommendations may be thin, nectar-like, honey-like, spoon-thick. Ooh, spoon-thick's rough. And then there's thickeners. There's all kinds of commercial thickeners out there. And typically, if you're in a rehab, what I would say healthcare setting, they'll have a few to choose from. And that's where nursing and things would help you. Now, compensatory strategies. So typically speaking, when your SLP is doing feeding therapy, we're typically teaching them compensatory strategies to maintain a safe swallow, make sure that they can continue to have the least restrictive diet. Now, here's some examples of some compensatory strategies. Some of you might be familiar. If you've ever been in the hospital or have had an issue, oftentimes these are some strategies we use, especially if you're weak. And a swallow guide, typically speaking, and honestly, I've made some of these for preschool because we do have preschoolers who have swallow issues, and we're trying to not do therapy per se, but give them those reminders so they're safe eating snack or safe eating lunch at school. So there's just some examples of something you might see. You might see it in a rehab setting. And oftentimes we might do some intervention to help see if we can strengthen. And there's some things with oromotor. So oromotor can relate more to swallowing versus speech. So oromotor exercises to improve speech are not necessarily appropriate. Oromotor exercises for swallowing is a different story. So just know those are kind of some differences there. And it's come up more recently, a few times now, recently at school, but it comes up a lot in clinic-based. So oromotor exercises. So let's say oftentimes we have a child is being seen for feeding as well as speech. So your supervisor might be doing the feeding therapy, but you as SLPA might be doing the language or the speech therapy. And this is where oromotor exercises get a little funky. So oromotor exercises to improve speech is not appropriate. Oromotor exercises for the purpose of swallowing likely are. And when I say oromotor, often what we're doing is just trying to maybe get some better control, or what I would say a lot of times we work on kind of, mouth closure, things like that. And it's more, I don't know, I want to say exercises, but this is the only way to call, I guess, best terminology for it. But if you're doing those, because they're doing it in swallowing therapy, that gets a slippery slope. So that would be something where you might tell, a parent who maybe wants you to review those. Say, oh, that's related to feeding. That's something my supervisor does. It's not something I do here in this, in this session. So being aware, if you're doing oromotor exercises, why you're doing them, the purpose of them, and if typically speaking, you shouldn't be doing them. So there are some other things too we might do with some pitch and voice that's related to swallowing. Here's some other therapeutic interventions. So you will hear this, you will see this, especially if you work in like a skilled nursing facility. And really, truly, when we're looking at skilled nursing, if it's short term, we're trying to get them better, healthy, so they can return back to their prior function. And I say subacute. So they're not in the hospital, but they're not ready to go home. So they're like in this, what I call the in-between, the subacute. So they're going to be there for 3 weeks till they can be discharged. Or we're going to start with 10 days, see if they need another 10 days. I don't know what the timelines are. I haven't been in one in a while. And I feel like a lot of Medicare stuff, dictates that. But typically speaking, you might be doing other rehab with them in a, subacute setting. So, and oftentimes too, when you're working with the family, making sure that you're also supporting what those safe things are, not necessarily providing therapy. So that's where it can kind of get muddled between the two. And typically speaking, dysphagia in and of itself, it's a lot of management. So you, as a speech therapist, you might be helping remind the family, hey, we're following these steps. Remember to, have your visual guide, your swallowing guide out, during meal times, especially when we're looking at our adult rehab population. We're working on those self-help strategies. How are we going to help them help themselves? So being aware that this is oftentimes a component of that, even if you're not providing direct therapy, you might be supporting using those techniques. You might be helping them, making sure they have the visuals out for their reminders, those kinds of things. So it can get a little gray. And if you ever in a situation where you're feeling like this might be a slippery slope with regard to licensure, that's when you need to talk to your supervisor about it and be sure you're clear on the boundaries. So, because that's what's hard. Oftentimes they never come to us and it's just swallowing. It's usually they've had a head injury, they've got weakness, they've got some partial paralysis, but they're gaining some strength. Now they've got reduced intelligibility, now they've got swallowing issues, or they've had, some type of aphasia. Now they've got all these language issues. So we need to work on language. We need to work on their swallowing being safe. We need to work on those, what I call executive function pieces to help them return back to independent or semi-independent level of care. So food sensitivities. Now, the other thing I will say, and this comes up because oftentimes in the state of Arizona and with our, what I would say our DDD population and home health. So that's the other place you kind of run into this sometimes is home health. Is oftentimes we get a feeding referral. They don't have a swallowing issue. They have a behavioral feeding problem. It's more about sensory-based stuff, which I feel like should go to the OTs. And it's OT-based, what I would call more sensory-based feeding difficulties. I feel like that should be maybe a collaborative approach, but it comes up often. Oftentimes, especially in home health, parents are like, oh my gosh, but he won't eat anything. Are you going to work on that? So that kind of comes up a lot. So let's say you're going to the home, you're doing a session and you go, it's like lunchtime. Oh, okay. And you might use food to work on augmentative communication. You might use food as part of your therapy, for asking questions, responding, whatever it is, using a picture-based exchange system. Often we use, food as kind of that motivator. So being aware of sensitivities, allergies, and then some of that sensory-based things. So someone's like, can I use food in therapy? You absolutely can. But what's the purpose and why are you using it? Be very clear that you have a good understanding of it. Because oftentimes too, sometimes we use food for someone who's, more just for exposure, not really quote unquote feeding therapy. So, so definitely we see it with autism. There's a lot written on this. And definitely we see there's definitely other health related things, not just with children with autism spectrum disorder, but it's also with other disorders too. So, And this is where team approaches can support these clients with lots of feeding difficulties. Definitely see a lot of gluten things. And there's kind of like this approach with get permission and really helping parents support, have a good, clear understanding of their expectations and what's really realistic, and then choosing the food. So oftentimes we will use food to work on language. It's a good motivator. Usually it's kind of one of those basic needs we have to do. So it's sometimes a good place to start. But definitely be clear on the purpose if you use food as an SLPA, especially in a home health or clinic setting. Why you're using it, what's the purpose? Because oftentimes these kids have a lot of different therapies. So for instance, school-based therapy, we have a little guy, he's got lots of food aversions. Now we're supporting his exposure to food. So at lunch, we put all the options out, even if we know he doesn't like it. Especially now with COVID, everyone's getting free food. We're not really, I don't like the word, we don't like to waste it, but there's things that we can, it's different when you're purchasing it versus we have it available. So we definitely try to give him exposure just for the sake of exposure, just for some of the language opportunities. So when he doesn't want, the sandwich, he doesn't like the turkey, but we figured out he likes ham, but not turkey. He likes yellow cheese, not white cheese. So we worked on some descriptive language with the food, and it's helped, as parents kind of, but we're not really doing feeding therapy. We're doing more language-based stuff, but using food as the subject matter. So that's where it gets a little, it gets a little muddled. So we've definitely had some discussions with his mom and actually some emails back and forth with his outside provider, his feeding, because he does do feeding therapy twice a week, about how we figured out things he liked. She just, she doesn't have him bring his device. So these were things that's nice as a group. And especially if you're an SLPA, you're a member of a team usually. And someone who's having feeding therapy, you're one member. And 9 times out of 10, they're getting other speech and language services besides feeding. So, and you might be servicing some of those other needs. So you just have to be aware and knowledgeable. And if things start to get a little, what I would say, unclear, that's where you might need to have your supervisor's support to help you, define the boundary, tell, maybe a parent, hey, this is what we're doing with this. This is not what we're doing, or this is what we are doing. This is what we're not doing. So sometimes just it's helpful for you guys. So picky eaters, definitely some things. There's lots of programs for picky eaters. There's lots of therapy-based components that you will see on picky eaters. And what are some other things? So the other part I want to say about this, and the reason why I spent a little bit of time, is when we are working with a client, and this is true even for our adult population versus just not just our young population, that food is so much part of culture, all cultures, not just American, but all cultures. Food is kind of what I would say when we're looking at kind of those ethnocentric based decisions. Oftentimes when we're looking at, typically speaking, we want from a communication standpoint, have a client be involved with their family in the important day-to-day aspects of their life, which oftentimes revolves around food. And what we want to do is support that communication piece, usually related to food, and also comfort. So a lot of what we're doing, especially at any age, truly, but what we want is, are we able to help them communicate what they need and what they want? And maybe can we help decipher sometimes what the issue is? So that's why food and communication really go hand in hand. And it's not just our young group, it's our adults too, because oftentimes we get a lot of pleasure from eating. We have a lot of social activities related to eating. We have a lot of engagement with others at mealtime. So there's a lot of communication things that come up related to feeding. And just sometimes as an SLPA, you sometimes, you shouldn't be doing feeding therapy. And that's where you might need some support to know, is this feeding therapy? Could this be viewed as that? Or is this just strictly communication? So that's what you need to be aware of and communicate to your supervisor. And really, truly at home health, it comes up quite a bit. And then definitely there are some other things that we do. So for instance, oftentimes what we find is that's like sensory-based stuff, something specific, or we figure out the texture that they don't like. And then what are some other strategies we can use to support, them being exposed to more textures and stuff. And that's why OT is a great resource. That's why kind of documenting some of that. And what's nice to see is that you as a member of a team, sometimes you get insight that other people just haven't had the opportunity to have. For instance, I used to go to Yuma. I would go with a OT and a PT. And it would be interesting is that sometimes I would be the first provider there, and I would have a different interaction versus the PT, and that was her last stop of the day. And just us working together, how many times things came up that I saw that she didn't. And just really working with your team about, okay, what's our purpose? What's my goal? And more often than not, you will hear every parent, caregiver, family member say, I just want to know, are they happy? Are they feeling good? Am I able to give them what they want? So they want those pieces. And so much of it does relate to food. So oftentimes too, when we're working on like intake, we've got all these different type of words, and there's kind of redefining the bite, mouse bite, bird bite, kitty bite, dog bite. Definitely you'll see some of that. And definitely we use some of that as far as with communication, especially in our augmentative communication. So we use it, we kind of review this vocabulary with we have two students at school that we kind of review this with on his on their AugCom devices, because he needs it. It's functional for him in other ways. And then these are kind of just some strategies. You kind of look at this. And oftentimes, if we're using food, we're trying to work on kind of that desensitization. So it's more of a texture or some kind of sensory component. So we might just be another person that's helping desensitize some of their aversions. So you kind of look through this, and this is what I want to say. So definitely eating's a natural experience, and it's critical for our daily survival. It's an essential, hold on, let me say this right. It's an essential physiological need, as well as an essential basic need. So it's definitely something that we're working on in a communication standpoint in some way, in some aspect. So definitely lots of things that come up with that. Families, usually this is where they always want the most help with. So as a care provider coming in a home, or therapeutic provider coming in a home, it's definitely things that, caregivers will come to you and seek you out and wanting your help. So a couple different things there. I just want you guys to feel confident that you have some idea and have some frame of reference, and always when in doubt, ask your supervisor. But if you learn nothing else in this module, basically, as of right now, SLPAs are not licensed to do any feeding-based therapy. That doesn't mean you can't use food in a session, doesn't mean you can't work on communication related to food, but from a perspective of swallowing, you're not doing any of that. Sensory-based feeding starts to get a little muddled. Right now, you're not licensed to do sensory-based feeding. You're not licensed to do behavioral-based feeding. But you might work on communication skills related to feeding. And that's where it gets gray. So basically, when you're working on a goal and food comes up and you're uncomfortable and you don't know the purpose, or you want to clearly define to the parent what you're doing or not doing, this is why you need to know what we do in a therapeutic standpoint. as SLPs, so you're informed and can ethically work within your license as an SLPA. So any quick questions on that before we sign off? We do have a swallowing observation and master clinician. There's our quiz. So definitely read through those presentations. There's a few other things on the read and review page. And then on the read and review summary. So review chapter 15. So like I said, you'll likely be treating somebody with dysphagia for other speech and language difficulties. So that's just definitely, you guys need to be aware about that, because that's where you really might need more of your support from a licensure standpoint from your supervisor. So definitely review that. It has great information. Any other questions? All righty. If not, thank you guys. I appreciate you guys.
Thank you.
Thank you.
Joining me. And then I'll post this, everything will be up by tomorrow night.